I believe that pharmacists are key members of any healthcare team, and especially in corrections and during this time of shortage, I believe that pharmacists can play a vital role because we are the medication experts. We can help and work together with the providers to recommend cost-effective medications, make sure that we provide monitoring parameters, look out for drug-drug interactions, making sure that the medications that the inmates are taking are both safe as well as efficacious for them.
PodcastRx.
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 Welcome to PodcastRx from Diamond Pharmacy, a show featuring the pharmacists and personnel behind the nation's largest correctional pharmacy provider. While we talk primarily about clinical and regulatory topics affecting the institutional healthcare clients we serve, we'll also occasionally get into the stories behind the people moving our company forward. This isn't just a pharmacy podcast, and you don't have to be a clinician or a pharmacist to enjoy it. As a young girl in West Africa, Nancy Chia was fascinated by the seemingly magical properties of medication to treat everyday illness. Now as a clinical pharmacist with Diamond's optics team, Nancy continues to parlay her childhood curiosity around medication into making a difference for vulnerable patients, especially regarding mental health care in the corrections environment. Nancy joins us to talk about her recent professional focus on psychiatric medications, her first impressions of the correctional pharmacy practice, the overrepresentation of mental illness in corrections, the shortages of mental health care professionals, and how ultimately pharmacists can help to ease an overburdened mental health care system. I'm Adam Campbell, and welcome to PodcastRx. Ready to get into it?
I'm ready.
We'll get started. All right.
Let's get it.
Well, I'm so happy to welcome back to PodcastRx Nancy Chia from the Optics Clinical Pharmacy team. Nancy, it's your first solo appearance on the show. How are you today?
I'm doing great, Adam. Thank you for having me here today. I'm really excited for a lot of reasons. Number one, we're in-house today, so I get to see everyone. And we're going to witness the solar eclipse later on today, so that's pretty exciting.
Yeah, definitely excited about the eclipse. I think we get something like 97% totality where we're at here in Indiana, PA.
Yeah.
So it's definitely going to be quite the event. Not another one for 44 years or something like that.
I'm excited about it. I'm excited about it. And this is going to be my first one too.
Oh, this will be your first one? Oh, okay. Great. Yeah.
So I'm looking forward to it.
You know, you were on the show a year ago, roughly, if you can believe a year has already passed.
Time flies.
Time does fly. And you were talking about your upcoming NCCHC presentation, drug diversion. That's what we were talking about.
True.
And you mentioned after the show ended that you were in the process of achieving some additional pharmacy certification related to psychiatric medications. You threw out that when that was complete, you wanted to come back on here and talk about that. So here we are a year later.
I know, I was
really
being
exciting.
very ambitious.
Yeah. well, you got said certification. You're a board certified psychiatric pharmacist now. That's a BCPP.
Still pending, but
still pending. Okay.
I just have to sit for the board exam.
Sit for the board exam.
Yeah,
okay.
but that's going to be happening at the end of the month.
Okay.
Yeah, so pretty soon.
Well, congratulations on all that, and best of luck with the boards.
Thank you.
But with your focus in that area, I wanted to have you on to talk more about specifically the psychiatric medication and in mental health care in the correction setting, which of course what you and the optics colleagues, your optics colleagues oversee so much of. And there's a lot to talk about in this area because psychiatric and mental health care, to put it extremely mildly, in the corrections environment, especially challenging.
That's true.
And medication being so central to the treatment of mental health maladies, a pharmacist, I would imagine, is more important than ever, especially when you factor in the challenges of the correctional environment.
No, I agree. That's definitely true. Correctional pharmacy or practicing in the correctional setting wasn't something that I was exposed to coming to corrections. And once I got here, That's
okay. Once you got here?
Okay. Yeah. Once I got here and I saw, I don't want to say the state of things, but I was really surprised at the overrepresentation of mental health in the correctional setting, right? Because over the last couple of decades, we've seen an increase in mental health disorders in the general population. So the odds of someone being arrested that has mental health disorder has also increased a lot. So we're seeing higher numbers of patients with mental health in corrections. So that's a growing concern. I mean, it's always been a concern. It's not something new, but it's definitely something that we're trying to improve on.
Absolutely. And so I wanted to talk with you more about everything you just talked about there.
Absolutely.
I want to explore all that with you. But before we get into that, I'd like to learn more about you from a biographical perspective, because just how you got here to optics and to Diamond. You've been on the show twice, but you've been in group settings. So this is something we couldn't really talk about. So Nancy, tell me a bit about you. Where'd you grow up? When and where did you decide to pursue a career as a pharmacist?
That's a good question. I mean, I'm going to tell you a little bit about myself. I'm going to tell you a story. It's going to be a little bit long, but please stay with me. Sure. So I grew up in Cameroon, West Africa. I did most of my studies there, I think up until high school. When I moved to the US, I believe that was back in 2010, 2011. But prior to coming to the US, my parents had come a couple of years ahead of us, chasing that American dream, right?
Sure.
So we're back home with my grandma. My siblings and I were left back home with my grandma. And I remember this one time when my mom came to visit, she brought this bottle of medications. I remember it was a big bottle, white with a red cap. And since I was the youngest of my siblings, my grandma entrusted me with carrying that bottle of medications almost everywhere we went.
Wow.
And when we went somewhere and her friends were complaining of like headache, back pain, or they had a fever or anything like that, she would tell me, oh, go into that bag, count out so many tablets and give it to this person. And she would tell them how to take the medications and stuff like that. Wow. So to me, when I was younger, that bottle of medication was like a magical pill, if you may, because I felt like it could treat everything, right? But then one day my grandma got sick, and she was sick. She couldn't get up, and she was very swollen, and we're all worried. But in my head, I'm like, why can't she just take the magic pill that we had? We've been giving it to everyone else. Why can't you use it? And later on, I found out that even though I knew that that bottle was a magical pill, they had other magical pills that were made for other disease states, and different magical pills are appropriate for different patients and treating different conditions. So that was my initial interest into studying more medications. So when we finally moved to the US, I was intrigued by wanting to know more about medications and how it applied, why that medication that my grandma was giving to everybody else, why did it work for them, and why couldn't she take it, and what did they give her, and how did it work? So that curiosity led me to pharmacy, and that's how I got where I am today.
Wow. That's a really impressive and interesting story. And it just starts in the family. Something so,
I know, it's so little,
simple, but leads to this much wider appreciation for medication as a whole.
Absolutely.
When you moved to the US, how old were you, and where did you first move to? And
we moved to, how old was I? I think I was 15.
Okay.
We moved to Buffalo, New York. When we first got here. That's where my parents were. I remember at the airport when we came in, my mom was like, it's going to be winter. You have to dress warm. And we're in West Africa, mind you. And our idea of like winter, we came in and we thought, oh, we'll bundle up, right? But the jackets we had, it's something that you probably wear during the spring. That's the warmest thing we had. So we came in and my mom was like, what are you guys wearing? And we're like, this is the winter jackets that we have, because it was so cold. And that was the first time I actually saw snow. And I'm like, what is this? This is a new experience. It's a new place, but it was fun. It was a lot of fun.
Well, and coming from West Africa to Western New York.
I know.
And the amount of snow, not just here's a little dusting on the ground, here's 2 feet.
Yeah. As soon as we got in there, I think the TSA agent that was there, he was scanning our passports, and he's like, what's your final destination? And we said Buffalo, New York. And he's like, oh my God, because we came in through JFK and then having a connecting flight to Buffalo. And he's like, don't go to Buffalo. And we called my mom. We're crying. We're like, why did you go to Buffalo? But it was an interesting experience for sure.
No doubt. Now you're established in Buffalo, New York. Where'd you go to pharmacy school? Where did you study that? Where did you get into that or indulge that interest in medication further?
Sure. So after I graduated undergrad, I went to Deauville. It's a private pharmacy school in Buffalo, New York.
Okay.
I was there for 4 years. And after I think I graduated in 2020. And after graduating pharmacy school, I went to Akron, Ohio, actually, to get my pharmacy residency certification. So I was in Akron, Ohio for 1 year. And after I completed that residency, then I applied to Diamond. And I've been here ever since.
And how did you discover Diamond, the optics team? What made you want to come here?
So that's an interesting question. Prior to applying to Diamond, I had no prior knowledge in terms of like the correctional side of things. I wasn't aware that pharmacists were practicing in corrections. So when I saw the job listing, it really piqued my interest because I didn't know what to expect at all. So during the interviewing process, I was very nervous because I wasn't really sure what to expect. And I mean, I've had other interviews with other companies and stuff like that. So I was weighing my options, but I was like, let me see what Diamond has to offer just out of curiosity. But during the interviewing process, the people that I spoke with made me feel very comfortable. During the interviewing process, I felt like they were very sincere with the answers that they were giving me and the questions that I had. So they answered me very honestly. And I felt like if I was to take this job offer, if it was offered to me, I felt like I was going to be working with amazing people in a very positive and supportive environment. So once they extended that letter of a job offer, I didn't hesitate to take it. And I've been here now almost 3 years.
Yeah.
And I'm really glad I did.
That's excellent. It's so good to have you here.
Thank you.
And as far as you said about you didn't realize the correction side of it, we've heard that from other people on the show that when they were coming here to Diamond, they didn't realize the breadth of pharmacy practice outside, say, the retail space.
Yeah, sure.
So for you, did you have did you have a preconception of where you were going to go? Were you thinking you were going to be a retail pharmacist, or what career-wise, what did you think you wanted to do?
I wanted to be more clinically involved, more so dealing with like chronic care management and have a little bit more say in the patient's treatment that you don't really get in the community pharmacy. So that's why I went to do my residency training in Akron, Ohio. And it was an ambulatory care outpatient, and they specialize in treating chronic care conditions and stuff like that. And so that was my main focus. I wanted to be, I don't want to say clinical pharmacist, but more so disease state management pharmacist, to be part of a team when it comes to disease state management.
Well, certainly optics was the right fit for you.
Yeah, of course. Yeah, for sure.
Now, as you've been with the optics team now for 3 years, the focus on psychiatric care, psychiatric pharmacy, how did that come about to be, where you're going to focus on that? Can you tell me about that?
So over the last 2 or 3 decades, we've seen, again, as I mentioned earlier, that there's been a dramatic increase in mental health. There's also been an increase in mental health awareness in a community setting. And prior to the pandemic that happened in 2019, 2020, we used to see that the statistics used to show 1 in 5 people reporting that they had some form of mental health disorder. And then the pandemic happened. And then that number increased to 2 to 3. So we're having a lot of conversations after COVID happened about mental health, how to treat patients better and stuff like that. But also in my personal life, I had exposure to my close friends and family members that were also going through similar situations. I felt like that exposure gave me a deeper understanding for mental health, number one, and also empathy for people that were going through those conditions. And then just being in a correctional space, and that the numbers also transition into corrections, and having more patients that were getting more questions from providers about how to manage patients with different mental health disorders. I felt like all of those things kind of helped me solidify my decision to focus on psychiatric care.
Well, when you're looking at the broader issue of mental health care in the corrections world, one word that comes up, if you just do one Google search, you'll see the word overrepresentation. That is, mental illness is far more prevalent among adults in the correctional population than in the community at large.
True.
The National Alliance on Mental Health, quote from them, about 2 in 5 people who are incarcerated have a history of mental illness. That's 37% in state and federal prisons and 44% in local jails.
Mhm.
This is twice the prevalence of mental illness within the overall adult population. And given these rates, America's jails and prisons have become de facto mental health providers at great cost to the well-being of people with mental health conditions. So,
Sure.
Nancy, for those who've never thought too deeply about why the prevalence is so high in the
Mhm.
corrections, in the correctional population, can you outline some of the reasons why?
Absolutely. So again, I'm going to go back to another story. It's going to be a little lengthy, but again, still stay with me.
Sure.
So last summer, I visited a site, right? I went there to perform their pharmacy audit just to make sure their pharmacy was up to date, up to standard. And before walking into the pharmacy, it's a little room bigger. It's a one room, basically. And they had like 5 nurses there. And this was a summer day, mind you, right? So it's hot and it's humid. And they're packed in that room, number one. And before I got out in the hallway, I could hear this loud banging noise coming from somewhere that I didn't really know. And once the nurse opened the door, I heard the noise even louder, and a smell hit me right away too. And I'm looking around like, what's going on? Are you guys in here? Am I the only one smelling this and hearing this? And so I look in the corner, and there's another little room off to the side, and there's a patient in there. So out of curiosity, obviously, I'm concerned. I asked the nurse, I'm like, what's going on? And she tells me, well, the patient obviously has some psychiatric issues going on, right? But unfortunately, there are no beds in the hospital for them to send this patient to the hospital. So, and they cannot leave him with the rest of the inmates. So they need a place to hold him for the time being until something opens up. I was like, okay, we left. A couple of months go by and I come back and he's not there. And I ask her, I'm like, oh, I don't see that patient here again. Maybe he's doing better. And she was like, no, he'll be back. And I was taken aback. I'm like, what do you mean? He's going to be back, right? But I didn't question. I didn't think about it too much. I moved to the next facility and the nurse and I are walking through the hallway and she hears a noise coming out from somewhere. And she's like, oh, that's Mr. So-and-so. He's back already? And I'm like, oh, you were expecting him that soon? And she's like, yeah, he's been here a couple of times. I know him. She can recognize the inmate from his voice, right? Mm-hmm. And stuff like that. So when I started looking into this topic, as you said, overrepresentation comes up. But I'm sure another thing that you probably saw was deinstitutionalization,
yes,
right?
Yes.
And so for us to find out how we got to a situation where the nurses have to be in the same room with the patient, if we go back, I believe it started in 1955. And during that period, they were trying to move away from institutionalization because a lot of people felt that it was a restrictive form of treatment and they had some abuse going on and stuff like that. Obviously, those places are not a vacation spots, right?
Right. So
they wanted to move and produce some form of an alternative, a community alternative where patients can be in the community and not locked up. The unfortunate part of that was the patients that were released into the communities, these communities were not given enough support. There were no resources in terms of rehabilitation or any plan as to how those patients were going to continue taking their medications once they were released. So into those communities, they had no form of support. So they had nowhere else to go, right? And most people felt that the people that were institutionalized did not really have mental health illness. They thought maybe they did not fit the societal standards of what was considered normal. But after that, we went back and you're looking at it, you see that 40% of those patients that were in there actually had severe mental health illness. They had schizophrenia, resistant major depressive disorder, and a lot of other things that really needed a place for them to go. And as a consequence of that, we see a direct transition where prior to that, let's say prior to back in 1970s, the population in the jail, I think nationally was like 500. And then you move a little bit and you go to 1994 and you see that the populations of the jail has skyrocketed more than 200%. Now you have more than 1.5 million people in jail. And you might be questioning, okay, maybe the population grew, but we always saw the population grew within that time frame by like 16%. So those patients were coming from somewhere, right? So it's either they go into corrections or they end up on the streets. So that's why we see that overrepresentation. And on the unfortunate thing with those institutions closing too is the fact that future generations that got sick had nowhere else to go. So if a patient is outside exhibiting disturbing behaviors, the police officer is going to take them to a jail rather than a hospital. So that's why we got to a point now where our jails and our prisons have now become the nation's largest psychiatric hospitals.
And with all of that in mind, a very stark situation, then, obviously the system is going to be taxed in a lot of places.
Absolutely.
So you're going to have shortages of staff and just poor ratios of providers to inmates. Can you give me any additional specifics on that as far as ratios and just the disparities, like in terms of numbers?
Absolutely. So when we're looking at the numbers, there was a study that was published in 2017 that estimated that in the year 2025, which is next year, Adam, we are going to have a shortage of approximately 31,000 less trained mental health providers. And that was because of a couple of reasons. Number one being that most of the mental health providers back in 2017 were already over the age of 55. So they were getting closer to their retirement age, number one. And also, they did not have a lot of residency positions for mental health professionals, and medical students were not also going into that profession as well. So we see that there's going to be a shortage that is coming up very soon, and that's not something that's going to be unique just to the correctional setting. It's going to affect everyone. I believe right now, with the current numbers that we have, people outside in the general population, 1 in 3 people cannot access a trained mental health specialist that they want to see. They have to wait months before they can see a professional. And how that transitions into corrections is that we have less trained mental health specialists in those facilities. Some of them have none, and others only have one that's in charge of the whole facility. So you can see how they are going to be overworked, and it's going to take a longer time before those inmates can get any access to care.
You also have a problem, too, of incarcerated people in particular, and sometimes just can't access care, even before they got there. And if they are on medication, for instance, if they get incarcerated, then they aren't able to adhere to that. They aren't able to resume that medication. So with all these big institutional issues that you just mentioned, Nancy, you're one pharmacist, but where, as a pharmacist, do you look at this and go, okay, here's how I can get started to help make a difference? Because this is so much bigger than just the pharmacy provider end of it. But where do you get started? Where do you see where pharmacists come into this and make things better?
That's a good question. I think as we pointed out, that there's a shortage of providers, not just mental health providers, but primary care providers as a whole, right? I believe that pharmacists are key members of any healthcare team, and especially in corrections and during this time of shortage, I believe that pharmacists can play a vital role because we are the medication experts. We can help and work together with the providers to recommend cost-effective medications, make sure that we provide monitoring parameters, look out for drug-drug interactions, making sure that the medications that the inmates are taking are both safe as well as efficacious for them. So I believe that we can work hand in hand with the providers to release some of the burden that they might be having.
It's easy. I know for myself, just as a lay person, when you think of mental illness, you think instantly of medication. Oh, that's the treatment, but it isn't the only treatment mechanism. And even the National Commission on Correctional Healthcare in 2008 Standards for Health Services, they said that, quote, mental health treatment is far more than prescribing medication. We need to give patients treatment goals with clear steps to achieve them, end quote. And with that in mind, as a pharmacist, even beyond medication, what are the ways then that can make a difference non-pharmacologically?
Yeah, that is a good question, and I'm going to try to answer it the best I can. When it comes to non-pharmacological options, pharmacists are definitely big advocates for that, because when you look at most of the guidelines, some of them recommend using medications in combination with non-pharmacological options, and that combination has been shown to be more effective than using maybe one of it on its own. And for some disease states, non-pharmacological options are recommended as the standard of care. So that's what you want to use before even using medications. So as pharmacists, I believe that we can work together when we're working with doctors. We can recommend some of those non-pharmacological options, such as sleep hygiene, relaxation techniques, exercise regimens, as well as nutritional diets as well. But some of the things when it comes to non-pharmacological options might need to be referred out to a specialist, because we've seen that cognitive therapy, behavioral therapy, things that are going to help those inmates gain social skills and also gain skills that can help them succeed once they are released is going to be very important.
Going back to the just larger institutional problem of mental health care, what kind of changes are you seeing facilities themselves implementing to address this problem?
I think they're doing a good job with the resources that they have. Mm-hmm. I know most of the facilities that we go into, once the inmates come in, they try to get a good history of what's going on. So if the inmate is able to open up and tell them exactly their past medical history, what medications they are on, and if they find that the inmate is going through something that's more acute, they can bump them up so they can be seen by a provider quicker compared to someone that maybe has like a chronic condition that is not as an emergency for them. So I think doing it that way and having providers maybe come through once a day and try to engage with the inmates and offer other services. I know some facilities were trying to do group counseling, because that way it can give the inmates a sense of community. Because in some places they have a lot of stigmatization when it comes to mental health, especially in jails. They might look at that person as weak, and then that inmate might become a good victim in terms of victimization. Right. So when you have a community, they know that they're not alone and they're going through this with other people. So having group therapy is something that I've seen some facilities implement that has been very helpful. This is just a bit of an aside, curious question of mine. Are there any specific mental illnesses that are more prevalent, like among, like we talked about, just general prevalence of mental illness, but are there any specific disease states that you find are more prevalent in the correctional population that, at least that you've worked with? So that's a good question. Most of the time, mental health, I'm trying to think of which one, but you see, most of the time with mental health, they're comorbidities of one another. So for example, if someone has major depression, then they have anxiety to go with it, right? If they have schizophrenia, they have other things to go with it. So to pick one is hard, but given the nature of your living environment, I will venture to say that anxiety and depression would definitely be the top ones for sure. But I did see a research that was done recently that actually showed that more than 40% of inmates had antisocial personality disorder, which I thought was very interesting, because people that have antisocial personality disorder, they usually have conduct disorder as well, a disregard for right and wrong and stuff like that. They don't really follow societal rules and stuff like that. So I thought that was very interesting. For sure. How do you, every day with your work with Office, how do you see the optics team making a difference in this area? Like you and your colleagues as a whole, how are you making strides in doing your part to help improve mental health care? So in the optics department, we're definitely, since we're pharmacists, we're medication experts. In most facilities, due to the shortages, as I mentioned earlier, some of them do not have a trained mental health provider on staff. And so that responsibility now goes on to their primary care provider or anyone else that's there. And some of those providers do not feel comfortable making any changes when it comes to mental health medication. And they might spend a lot of time maybe Googling, trying to find answers to questions on how to switch from one medication to the other and how to best manage patients. So the optics has all those resources, and we try to provide those answers to our providers as quickly as we can. So that way we can help save them time. They don't have to go looking for those answers somewhere else. We can save them time to help them see more patients and spend quality time when they're with the patients rather than worrying about medication management.
And of course, the goal too is, obviously delivering the highest care, but also
Absolutely.
helping, cost is always a concern too.
Absolutely.
And so making cost-effective recommendations as well.
Absolutely.
As far as your work with optics, have there been any facets of psychiatric or mental health care in corrections that have really challenged what you thought you understood about it? I think you alluded a little to it earlier, but can you elaborate on that more?
I think I mentioned this during the last podcast. Working in a correctional setting is definitely challenging, but it's interesting because there are a lot of things that if you're practicing on the outside, you don't really think about, right? If you're recommending a medication outside, you're thinking about, is it effective? Number one, is it safe? Can they afford it? But in the corrections, you have to go the extra step and think about the potential for abuse of that medication. Because unfortunately, most of the inmates that have mental health illness also have a comorbidity of substance use disorder, and they might be looking for a substitute to their drug of choice from the outside. So that's something that you have to think about when you're making recommendation. And I think it's a challenge because you have to catch yourself when you're making those recommendations.
As far as just the rewarding, what is most rewarding about working as an optics pharmacist, but not just, and we'll take the discussion all the way out from just mental health for a second, but what for you is most rewarding in that regard? I mean, you don't get to do direct patient care in the facilities, but from where you're at, what are the most rewarding aspects of the job?
I think the most rewarding aspect of it is when a patient comes in and they have a chronic condition and, they're going through something and the provider is stressed out, and then they give us a call and we walk through that patient's profile and come up with a recommendation plan and see that plan implemented and that patient get better over time. I believe it's very rewarding.
And to go back then to your focus with psychiatric pharmacy, mental health care, what are your own personal goals working in this field, your focus in it? How do you, Nancy Chia, hope to make a difference?
So for me, I think my plan and the curiosity that I had from the get-go when I got into pharmacy in the first place, learning about all the different magic pills, I believe that's still my goal. I still want to learn as much as I can about the different pills out there and what makes them special and what patient is going to benefit from what medication. Because especially with psych, one thing doesn't work for everyone. So finding the little differences that can help to improve someone's life is my main goal. And hopefully with the knowledge that I acquire, I want to be able to provide that good quality care to every patient that we encounter.
Good quality care. It's what we're all about. Nancy, I do look forward to talking with you more about some specific disease state topics really in the care within in some future episodes here. So
absolutely, that's going to be fun.
But it's great to kick off this from a more broad, wide-ranging discussion. And I just want to thank you for sharing your time and expertise and some of your personal stories. Really appreciate that, and look forward to talking to you more, picking your brain more about this particular subject.
Thank you, Adam. Thank you.
You're welcome. And we've only scratched the surface, truly.
There's so much to talk about. Much to talk about, and I'm excited for it, for sure.
Me as well. PodcastRx features conversations with healthcare professionals. The statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein. But we do hope you enjoyed them.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Keep up with our show on all the major podcast platforms, including Apple Podcasts and Spotify. New episodes usually drop the first full week of each month. Where possible, please rate and review the show to help us reach more listeners. If you have any questions or feedback for PodcastRx, we'd love to hear it. Shoot us an email at podcastrx@diamondpharmacy.com. We thank you again for listening.